Good afternoon, everybody. My name is Nick Barker. I coordinate our bite-sized lecture series. Today, I'm excited to introduce our speakers, but first I would like to state our mission, which is to emulate SCCM's mission, which is to secure the highest quality of care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. Today, I'm excited to introduce Dr. Spencer Lee. He's the medical director for the Department of Pulmonary and Critical Care at Northside Hospital, Cherokee, as well as the director for the PERT program there, and he's also director of the resuscitation committee. I'd also like to introduce Bob Baton. He's a clinical assistant professor at Mercer University, physician assistant program, and a physician assistant for critical care at Northside Cherokee. And finally, Ayan Jun, who is a clinical pharmacist in critical care at Northside Cherokee. They're going to discuss pulmonary embolism and the utilization of PERT in 2023. At this time, I'm going to hand it over to Dr. Lee.
Well, thank you so much. No, we appreciate the opportunity to all be here today. And we were looking at different topics, and when the topic of pulmonary embolism was discussed, in my world, is very exciting. Anytime where you have a little bit of controversy or a little bit of a gray zone area, if you will, I'm a nerd enough to really get into it and really want to dive into some of the literature and the opportunities there. I was privileged to be a part of our PERT creation here at Northside Cherokee, and I wanted to walk through a little bit about what PERT really is and what the goals of it are. And I know some people view it as a lot of logistics and hurdles, and there's definitely some bumps in the road with that, but also the potential utility and especially moving forward in regards to that. So I think it's only going to be increasing. And hopefully with the data that we're getting with some of the studies that are ongoing, getting more and more information, really just to help our care in these patients with pulmonary embolism. So as everyone knows, PE is a huge topic, and we really wanted to hone into just a couple different things today. So I'll talk a little bit at the beginning in regards to what PERT really is, the team kind of approach to it, and sort of the dynamics between that. And I think it doesn't matter if you're in a 50-bed hospital or 5,000-bed hospital, I think having an approach to this care is a great thing to do. So really the role it serves, the team involved. We'll have Robert talk a little bit about the echocardiograms and kind of the findings and what we can bring from a critical care standpoint, especially in the world of POCUS. And Ayan to talk a little bit about the anticoagulation, which is really the backbone of PE and as far as the care in regards to that. And I really just want to speak on, and I'll probably date myself a little bit, but the care of PE definitely has gone way away from, hey, everyone just gets heparinized and we move on. And so I think it's exciting today to talk to a group of highly educated people that will have the same interests as I do in regards to, this isn't similar, or I guess it would be similar to kind of stroke care. Again, when I was training, it was like, hey, everyone got an aspirin and statin, there wasn't much else, and that world has greatly evolved. And the same with pulmonary embolisms and the aspect of PERT. We've really seen a lot of changes in that world, and I think it's going to be exciting over the next few years to see where we're going with that care. So in regards to PERT, or this pulmonary embolism response team, I think everyone's used to hearing that term, seeing it in the literature. You know, what does that really mean and the kind of where it came from? It was a concept that was kind of devised at Mass General around 2012. So again, this concept isn't too old. It was something that was looked into before that, of course, by their team up there. And why they really were looking into that and doing a lot of research into pulmonary embolism response teams and care in general was seeing just the wide variety of care that these patients were getting between their hospitals and just systems throughout the United States, and saying, hey, why do very similar patients get completely different care when they come in with a pulmonary embolism? And they were seeing throughout the years the incidence of pulmonary embolisms only going up. And a lot of that, I'm sure, is derived from the D-dimer testing that was developed along with CTAs. I think everyone in our world seems like everyone we're getting from the ER is getting CTAs now, and we're picking up more and more and more. And as that incidence increased, so did the mortality. So even though we were getting more information, seeing these more often, treating them with anticoagulation, that mortality, according to AHA, was going up about 0.5% a year. So they really wanted to come up with a better way to standardize some of these gray areas. So that's where this team approach came into play. Very similar to like a heart team, you know, when you're looking at valves or like surgeries like TAVRs versus open, or in my world, it's more like lung nodules, lung cancer, where you meet with multiple different specialists from different backgrounds to come up with a very individualized care for that patient. As we've seen with a lot of our disease processes, it isn't a one size fits all. And I know we all appreciate that, where, you know, you can't fit into the algorithm. whether it's sepsis, whether it's PEs or otherwise. Like, you can't just go down this line and treat everyone the same. So this was aimed at looking at the individual features, really risk stratifying these patients and trying to figure out who needs what therapy and where we should go, kind of in a multidisciplinary approach. So most of the teams are involved with a whole different subset of people. And I think this is really the exciting part, and the part where we were able to build out our team here. And again, we're about probably 350 bed hospital. And again, it doesn't matter if you're huge or small, you could develop this team. You could have 3 or 4 people. I think some of the calls in Mass General are 15, 20 different providers. So really across the board in regards to who you would want to involve. Most of the time, people would say it would be some sort of critical care in these patients, an interventionalist, whether that's an interventional radiologist, interventional cardiologist, and then having pharmacy, radiology, pulmonary, whether you have CTS involved, vascular surgery, really endless in regards to who could have a foothold into this care. So I broke down kind of what we have involved, and I think these are kind of the core sets of people that really could have good impact and good input in what we've seen over here. We get involved with the primary care physician of that patient, whether it be the ER or whether it be internal medicine provider or anyone throughout the whole hospital. Again, just to have that history and that background, knowing that patient first, maybe there's something they picked up on that you didn't. Our PERT care here is driven by our critical care attendings, whether they will see these patients, get the history, get all the labs, the echocardiogram, everything together and present on this call. We do involve pharmacy, immensely valuable in regards to this, whether it be anticoagulation, heparin, Lovenox, even TPA for some of these decisions, and just having their input. Maybe there was something there in the background that you missed and the INR really was, 25 and you didn't see it, kind of thing. So our interventional team is interventional radiology over here, and we do lean heavily on cardiology. Like, we are very good, and I know Robert will take us through some of the echo features that we see from a POCUS standpoint. But we have a cardiologist on the call to really tell us about that RV, what it's looking like, and we hold that very highly when it comes to treatment decisions moving forward. And I know everyone kind of knows what we're hinting at in some of these gray area kind of intermediate high risk patients, or maybe those contraindications to TPA patients, and really hone in our focus to the PERT team being valuable in those scenarios. So you can't see them all, and I know everyone gets really nervous about that, and some of the data behind it is, even though they did a single center study pre and post PERT, or when they had a team, when they didn't, there was still a huge amount of pulmonary embolism patients that weren't PERT, or there was no call for them, versus the amount, maybe it's 15, 20% of the overall PEs that you would see in your institution. So it isn't like you have to see them all. I think there is kind of a niche population in here that really that value is found. And that really is that high risk intermediate and contraindication to TPA. I think you'll hear that as a reoccurring theme. And really the goal is to get those patients anticoagulated in a timely fashion and to ultimately their in destination of therapy. Whether that is just anticoagulation, whether that is systemic TPA, catheter directed, maybe surgical embolectomy, but really facilitating a very much timing for a lot of those features. Now, I know for an example of her sepsis, some of the features were like, hey, does it really need to be within 5 minutes, 1 hour, 6 hours? And antibiotics really panned out in regards to that. I do believe getting these group of patients anticoagulated sooner is something that you would see within the PERT, and just looking at the data behind that. A few of the other kind of single center studies have shown not only time to anticoagulation that was a little bit faster in the PERT group, but also just, like I said, facilitating that care moving forward, whether it be catheters or otherwise, and the length of stay. So if you're talking a PERT discussion where this is a highly complex patient and you're coming up with a decision at that time, it really facilitates that care of the patient and potentially negates an ICU admission or getting them out of the hospital. Almost all of the studies in regards to their PERT programs, have shown decreased length of stay. So with this, I know there's been a big push since 2015 for a lot of hospital systems to kind of create their own PERT programs, and the idea of this PERT consortium, where data can be placed into this database, if you will, in regards to gaining information on these very highly complex patients, just to help everyone throughout the world, to be honest, in regards to choosing the right care for these individual patients. There will be, and I'm sure as everyone knows, through the PERT consortium, a Center of Excellence designation that they're gonna start taking applications for towards the end of this year, whether you're kind of a comprehensive center or regional center. So I do think it is something that as the years go by, it will be more time-based and there'll be more metrics behind it. Some would akin that to like a STEMI care, and again, with a 90 minutes and things like that. Again, what is really defined in those metrics in care moving forward, I think, is to be determined, but we do truly believe that there will be more time-based metrics just in regards to getting the proper care for these patients as soon as possible. So I wanted to put this on there just to show you, this is from the PERT Consortium in regards to, this looks all kinds of crazy, and if you stared at it for a long time, I promise you'd be able to say, okay, here's where the benefit is, here's where it's not, makes it look a little bit complex. But really what you're seeing here is that overall theme again, which is in regards to this intermediate high risk and these contraindication to high risk. When we were creating our program, one of the big questions that came up all the time was, you're making us jump through all these hoops, we're doing these phone calls, are we going to slow things down? We want to treat these people as quickly as possible. And we actually have seen the opposite. We're able to get them anticoagulation faster, get them to their definitive therapy faster. And it is not meant for, the low risk patient, which we all know what to do with, or the patient that's like arresting in front of you. So it's really meant for these that you have a little bit of time to really discuss and come up with the proper treatment plan. On those two outlying ends, definitely PERT hasn't been shown to be as useful, again, depending on what you have available to you. But those are the two big categories that are shown to be of use. And that is this intermediate high and the high risk with contraindication TPA. Everything else in between, like I said, I think most of us would agree, if you're really low risk, you get anticoagulated. If you're in this intermediate and otherwise everything's okay, maybe you have a little biomarker, maybe this or that, but the echo looks okay, most people would be okay with putting you on anticoagulation alone. It's that intermediate high that has really gained the most interest, not only from the pulmonary critical care world, but of course from device companies, cardiology, looking at that world, along with the massive PEs, of course. The data behind that and giving systemic TPA, and again, with that contraindication, becomes a very difficult decision. So really coming up with the best treatment approach for those patients. So here's what we've kind of done to kind of simplify that algorithm a little bit and how we classify people. And again, I know there's a lot of gray even with how people classify people in regards to PESI or other scores that are out there. We kind of simplified that down and said, here's where we really want to utilize our PERT. Again, we don't want you to go through all these logistics when we know you're low risk and then potentially going home in a day, but really looking at that high risk intermediate group and the contraindication to TPA group. And I think that's really where the benefit has been shown. And I know a lot of people in their programs have shown a little bit more advanced therapies or reperfusion, if you will, in that category, which we'll talk about a little bit later. I do think there is a lot of research in that world of what to do about that, whether it is reperfusion versus anticoagulation alone. But that's kind of what our goal is, to see very quickly if you are in that category, if you need to have a PERT consultation, and then if that's the case, then to make a treatment decision from there. So the key factor behind that probably goes without saying, but how is the right ventricle? That's always going to be the question. We do obviously check BNP and troponins for all of these patients for biomarkers, but a lot of the discussion is behind the RV in regards to, is it normal, is it not, does it appear more chronic, is this acute? Really the world of echocardiogram and specifically POCUS has really shown to give us that information very quickly. So if we're able to assess a patient, whether they call us from the ER, come down their ultrasound, look at the RV and say, hey, this person's troponin is 5, their BNP is elevated, the RV looks blown out, that really means something to us, and be able to do that in real time. We all know that stat echocardiograms still take a little bit of time, so being able to get some of that information yourself and really make a quick decision is very useful. So as the prominence of POCUS has come along, we've definitely utilized it in this world just to risk stratify patients a little bit quicker, not only to get them anticoagulated, but get them to their definitive therapy a little bit faster. So with that being said, I want to go ahead and hand it off to Robert, who's going to go through some of those features that we're looking for and show you some cool pictures and videos behind that.
Thanks, Spencer. Are you guys able to see the slide screen appropriately? Yes, Dr. Lee. All right. So risk stratification. When we move forward, this is kind of from the perspective that the pulmonary embolism has already been diagnosed. And so now what do you do? And as the good Dr. Lee described, there's three basic categories, with the two on the ends being somewhat straightforward what to do. So how do we, sort of go and, figure out who is intermediate, and then really teasing out, is it intermediate high or intermediate low? For the most part, this intermediate high, uh-oh. Uh-oh, yeah, technical difficulty here. All right, you guys able to see this slide okay? Yeah, okay. So,
Yes, thank you.
pardon me?
I was saying thanks. Yes, we got it.
Okay. Sorry, I can't see my slide now because all of this webcam stuff is in the way. So we've, historically it was called a submassive group, and it's now been changed to the intermediate high and intermediate low risk. And as Dr. Lee described, the intermediate high has, both elements of RV dysfunction and some type of biomarker abnormality. When you're sorting out who is in low risk, a whole host of different scores have been considered, but ultimately, we've settled on using the simplified PESI score, or SPESI. There's a kind of a host of data out there with folks trying to really get to the bottom of, how can we best identify whomever. But as Dr. Lee described, it's really, teasing out the high and the low, and really, sinking your teeth into the intermediate risk folks. So once someone has been determined to be low risk with a PESI score, which is really just several questions that are asked of the patient that are readily available without any testing, you can use that as far as your scoring system. And these other ones don't really, they're not as useful for the average person. And with regard to PESI, this is what the European Society of Cardiology guidelines have, ultimately used. They're very validated. There's no labs required, and this can be accomplished without even looking at the RV. The Hestia score is sometimes referred to, but again, this one requires that you look into their RV function in some capacity, and or some other labs. So before you have any labs at all, you can really sort out their risk stratification. So what is the PESI score? Well, it's pretty straightforward. This is taken from one of the online calculators, and really it's just involving the age, the history of cancer of the patient, do they have any other kind of chronic cardiopulmonary disease, what is their heart rate, are they tachycardic or not, what is their blood pressure, is their systolic blood pressure above or below 100, and are they hypoxic? With oxygen saturation, the line in the sand being made at 90%. Any one of those will result in having a high risk. So it only takes one abnormality to kick you out of the low risk category from a PESI standpoint. When we look at the risk of mortality, this categorizes people. Here's somewhat with regards to the ESC guidelines. Once someone is PESI positive, they've now moved into either the intermediate or the high risk category. And so this is somewhat straightforward. I know Dr. Lee had a pretty complex description with his diagram, but this sort of lays it out from a pretty straightforward standpoint. When they're talking about cardiac biomarkers, the one that's most tested is the troponin, but quite often the BNP also can be incorporated as well. And then when we talk about signs of RV dysfunction on the imaging test, that can be as simple as just the RV to LV ratio on a CT. which is pretty convenient since the CT angio is typically the test of choice for diagnosing the pulmonary embolism in the first place. But sometimes that leaves a little bit to be desired, and that's a static image, which sometimes doesn't tell the whole picture with what's going on with the RV. So the primary cardiac biomarkers are the troponin and the BNP or pro-BNP. However, there's a fair amount of data supporting, checking a lactate. Obviously, if the patient is generating a lactate, something is probably not going right. This is kind of the intro into the patient who may be exhibiting signs of normotensive shock. Also, there's data supporting that if you have elevated creatinine or sodium, or hyponatremia on admission, that increases, those are risk factors for mortality as well. Some other labs that can be checked, we don't have available to us are the cystatin C, copeptin, and the HFABP. With regard to imaging, what we can be doing is obviously they're getting a CT, which really just gives you evidence of, is the RV dilated or not. Sometimes you can see, dye backing up into the hepatic vasculature. But as Dr. Lee mentioned, for the echo, we're namely going to be looking at RV function, and then how is that done? Another note is if the patient's hypoxic, performing a bubble study may be of use as well, as those RV pressures can potentiate a right to left shunt. Now, the presence of a DVT with lower extremity ultrasound factors into kind of the bigger picture of, when you're doing these complex risk stratifications in the patient who has bleeding risks and so forth. But it doesn't really impact the overall treatment plan, with the exception of if the interventionalist who may be doing a percutaneous intervention may opt to choose a different extremity if there's a clot in one of them. Presence of a DVT, however, does worsen overall survival just in the big picture. So, when we look at the mortality risk, some places are sending folks home if they're deemed low risk and just starting them on oral anticoagulation. A lot of this is more in the international community than here in the United States. But the risk isn't zero in that low risk group. And, part of that is, they may have, let's say, a negative biomarker, but, not always is the RV checked initially for all these folks, or perhaps it's just the RV is checked on the CT. So sometimes there's, I think subtle nuanced findings for RV dysfunction that are maybe not considered, and that's what's lending itself to this, zero, not being zero in the low risk population. My computer decided to do something else again here. All right. And again, when we look at this intermediate high and intermediate low risk, the this is a very vulnerable population of people that really requires a team-based approach to help minimize their risk. How do folks die from pulmonary embolism? Well, this is taken from the European Heart Journal, and some folks refer to it as the death spiral, for lack of a better word. But you can sort of just see as time goes on, initially you may see RV dilatation. That may be kind of the early signs of something on the CT. But things that the CT, really doesn't do a good job of it is sort of examining all these other effects of ongoing decline and heading towards worsening shock. And so, really many of these parameters can be derived from, echo and ultrasound. Namely, things like decreased cardiac output. So here's what they're often looking at on a CT, and we've labeled the LV and the RV accordingly. And you can see by eyeballing it that the RV appears to be at least as big, if not bigger, than the LV. And this is when this is the main image or static image that radiologists are using to say, oh, they have some evidence of RV dysfunction. Other things that play into the role, though, it's I'm not going to dog on CT entirely. And there's lots of subtle nuances. Pulmonary trunk enlargement, all right, where it's the main pulmonary artery is greater than the aorta in size. They can often appreciate that there's flattening or bowing of the septum towards the LV. And then, as I mentioned, there can be other features of RV failure, such as IV contrast going into the inferior vena cava, as well as into hepatic veins. Here's another image taken from the European Heart Journal guidelines on management of pulmonary embolism. And here's some of these are the main echocardiographic findings that they recommend be investigated. So the first one is a parasternal long image, okay? And we're not all echocardiographers here, but you can see where the RV is in this image being enlarged. Here's maybe a more familiar image, an apical four-chamber view where the RV is noticeably larger than the LV. This is a short axis view where the heart is cut down the middle. Normally this LV is round like a letter O, all right? And now it's been turned into like a capital letter D. So this is flattening of the septum where it's normally round. If there's increased right-sided pressures, you may expect that the vena cava will be dilated. And then there's some other fancier settings here where we're using pulse wave Doppler in a parasternal short axis to look for special patterns where there's this notched mid-systolic notching that is often seen. This is kind of more for advanced or certainly formal echo users. There is a handful of advanced POCUS users that may be able to get this image. And then also looking at the tricuspid regurgitation jet. Again, this is kind of more of an advanced thing that many POCUS users won't have that skill set at their fingertips. Many people can stumble across finding a clot in transit, right? And that also is something for the PERT team, as that requires a special consideration and care. Looking at the TAPSE, all right, it's a kind of a fancy name, tricuspid annular plane systolic excursion. It's really not very complicated, and this is within reach of most beginner or intermediate POCUS users, where you're essentially just interrogating just where this on the annulus here, the tricuspid valve, as the heart squeezes, this will move, all right, with each systolic contraction. And that trajectory on how far it goes corresponds to reasonably well to the function of the RV. And so if it's not moving very much, then that implies that there's kind of poor function, all right, and it's measured in millimeters. And they do this in M mode, which is a fancier mode, more than just 2D, and it's really just focusing just on this one spot. And you can see as it goes up and down, it measures that trajectory of the slope. Similar to TAPSE is using tissue Doppler on the tricuspid annulus, and instead of measuring the distance that the annulus travels, it's looking at the velocity of that tissue. And many POCUS machines don't have tissue Doppler, so this is sometimes out of the reach. But as you can see, quite a number of these, looking at the RV enlarged, looking at the RV to LV ratio, appreciating something called McConnell's sign, which we'll look at later, looking at flattening of the septum. Many of these things are available with just the portable ultrasound that's hanging out in the emergency department or in the intensive care unit. And the average, emergency medicine or critical care provider can, should have the ability to acquire these images and interpret them. So we looked at the ESC guidelines. This is kind of summarizing the previous screen, but there certainly are some other parameters that they didn't include, which may impact the care and help with risk stratification and maybe moving someone from a intermediate low to intermediate high risk, or certainly could potentially even put someone from the low into the intermediate risk. And so looking at the left ventricular outflow tract, you can determine a cardiac output with this means of interrogation with the velocity time integral. And we'll cover that in an additional slide in the future here. And then similar to that, in the RV outflow tract, this is a little bit more challenging to acquire this image, but it's in the same line of reasoning and to determine basically the stroke volume of either the RV or the LV with this VTI approach. So as Dr. Lee mentioned, the PERT consortium is soon going to release the standards for who is going to be able to be recognized as a center of excellence for pulmonary embolism management. And they'll have two basic, this is kind of adapted from the 9th annual PERT consortium symposium. And essentially there's two categories. There's a regional, and then there's a comprehensive centers of excellence. And with the main difference being the availability of a formal echocardiography from an imaging standard standpoint. There's certainly going to be other standards from technical abilities and treatment modalities. For example, having in-house cardiac surgery availability is going to be a requirement for the comprehensive folks. But just from an imaging standpoint, that the main thing separating the two is going to be 24/7 echo availability, and they haven't really spelled out if that means in-house echo or if there's a time for an echo cardiographer to arrive. But certainly point of care ultrasound is listed as a requirement to for either of them, and so it's certainly reasonable for folks to develop that skill set and have someone in-house who can do it. So when you're trying to risk stratify someone, this is kind of reflecting back on what I mentioned in the previous slide, where what things can you actually do with point of care ultrasound for the average user, all right, for the average emergency medicine physician or the average critical care physician or or their PA who may be able to do it as well. And so with that in mind, the things listed in green are pretty straightforward to acquire those images, with the yellow ones being maybe a slightly advanced user, and then in red these are kind of more challenging things to acquire, which maybe the really advanced user can acquire. But for the vast majority of all these images, again, this is in comparison to just relying only on the CT, which just sometimes facilitates medical decision making. So we'll take a look at a couple of images here. Hopefully my computer will continue to work since I've wanted it to. I apologize. This was working great yesterday. So when we look at a parasternal long axis, all right, you can see that this is a normal right ventricle here. I don't know why I said, there we go. And in this image over here, you can see that the RV is massively dilated. And so that's, again, just eyeballing it. There's no special measurements that are needed. When we look at an apical 4-chamber view, one can see where the right, this is a normal size right ventricle, and over here is a very dilated right ventricle as well. And then we've got this characteristic McConnell sign, where we've got basically hypokinesis of most of the right ventricle, with just the apex squeezing. This is a parasternal short axis view with the relevant anatomy listed. And you can see where this is like a O, this kind of, left ventricle being a slice down the middle. And if you look at this side where the RV has the pressure is very high, it's flattening that septum in this view. All right, and they call that a D-shaped septum because it looks like a capital D. We mentioned the inferior vena cava. Again, these are pretty easy images to acquire. And just by eyeballing this, you can see that the inferior vena cava is not, I would say it's normal size and it's got some respiratory variation. And in this view over here, it's very engorged or plethoric and distended. All right, and that again would suggest that there's elevated right-sided filling pressures backing up into the vena cava. Back to our apical four-chamber view. All right, sometimes you can see a mobile thrombus. And, even for us who don't look at echoes all the time, you could probably see there's something flopping around in there, which isn't good. All right, and so here's the TAPSE that we were mentioning, the tricuspid annular plane systolic excursion. And essentially you get your apical four-chamber view and you draw a little, the M mode button is pushed. And what that does is just only along this one line is dragged out over time and interrogated. All right, and so as you can see, as the tricuspid annulus goes up and down, it's reflected here in the up and down stage. And then by looking at the slope with kind of easy to use calipers, it will tell you the distance that it traveled. And typically over 16 or so is considered, or less than 16 is abnormal for most patients. Here's an example. All right, this is on one of the Sonosite machines here, so you can see it's done by the average user, and this didn't move very much. So again, looking at this little bit of white speck here, which is the tricuspid annulus, and as the heart beats, it's going to kind of squeeze it, and it's going to have a movement upward, and that's reflected here in this M mode setting. All right, and then you just measure the slope in this fashion. All right, and it tells you that it's only going 11.5 millimeters. A lot of times you can just eyeball the TAPSE. All right, and I think Dr. Lee has certainly done this in the ED, and you can just eyeball this, and you can tell that this annulus here with the tricuspid valve is barely moving. It normally should be going way up here, and so it's not. All right, and so for that, I don't know what the exact measurement would be, but certainly not very high. Now, what in the world is this LVOT VTI business? Well, essentially, we're looking and putting up, and this is with done on a device that's on an Android tablet, just to show you the functionality of these portable devices. And so, interrogating with a type of Doppler called pulse wave Doppler. And this is an apical 5-chamber view where the LV outflow tract is sort of coming right into here. And so when the heart is ejecting the blood out, it's all going right along the path of this line. And right in the middle here, it's hard to maybe see, there's a little, looks like an equals sign. And that's where we're interrogating the blood flow through the LV outflow tract. And then it gives you kind of this characteristic shape of flow. And this is a flow over time. It also makes a cool noise, the whoosh whoosh noise that you may hear when the sonographers are doing their job. And it's an integral. All right, so back from when we had to learn calculus to kind of get the area of something weird in shape, this is sort of what it's doing. All right, and in general, something above 16 or so is considered okay. And so on this one, trace it out, and it gives you this number right here of 18. And this individual here, that was probably on me. I have a low cardiac output sometimes. The VTI was low. So just to kind of explain it a little bit more, because I know there's some folks in the audience, certainly the pharmacists are good at doing a lot of math. Essentially, in the parasternal long view, right, we're looking here is the aortic valve where where the LV is over here, and here's the LV outflow tract. And if you measure the diameter of this, all right, you can end up getting, the radius, and then do a whole pi r squared to get the area of a circle. And then what the Doppler tracing is doing with the pulse wave Doppler is it's, creating this basically a stroke distance. And we're able to combine the two of those and basically get the volume of a cylinder, and that's the stroke volume. And so once you have that number, then you can multiply by the patient's heart rate and derive their cardiac output. And we spend a little time on this because a lot of folks can have a low cardiac output, but a normal blood pressure. And maybe their heart rate is a little bit elevated, in a compensatory fashion, but it's not, profoundly elevated. And there's I think this is going to be more incorporated into future evaluations of the patient, just to tease out who is really, are they truly intermediate low risk, or are they maybe intermediate high, and we're just not seeing those subtle findings just yet. So the intermediate risk folks are categorized into the high and the low risk, with the lab markers being the troponin and BNP as one of the components, and then some type of imaging that's demonstrating RV dysfunction, whether that's on CT, echo, or POCUS. We talked about POCUS today because it's feasible to achieve most RV dysfunction parameters, and it's readily available, and it may decrease the time for PERT activation to make decisions on things. Thank you.
All right, thank you, Bob. So in the next few minutes, I'll be discussing the pharmacologic options for PE management. Everyone can see my slide okay, right? All right. So here is an overview of some of the topics that I'll be going over regarding pharmacologic strategies. These include thrombolysis and submassive PE.
Yeah, I'm sorry. I don't think we're seeing your slides. I apologize.
Okay,
I was trying to get off you.
Okay, let me share. What about now?
Yes, thank you.
Okay, sorry about that. All right, so yeah, like I said, in the next few minutes, I'll be going over the pharmacologic options for PE. And here's an overview of some of the topics that I'll be going over regarding pharmacologic strategies. And these include thrombolysis and submassive PE, half dose versus full dose alteplase, the role of tenecteplase in PE, thrombolysis and cardiac arrest, and finally the choice of anticoagulants. So first, the decision to give systemic thrombolysis depends on the type of PE and the patient's risk of bleeding. For massive PE, it's a little bit more straightforward. Fibrinolysis with alteplase is usually recommended as long as there's no contraindication. For submassive PE, it really depends on the patient's risk factor. Like Dr. Lee mentioned earlier, fibrinolysis may be considered as an option if the patient is in the high risk intermediate category, or if there's evidence of progression of illness. Also, the benefits and risks should be weighed for each patient. Some benefits of giving systemic thrombolysis are rapid symptom resolution, stabilization of respiratory and cardiovascular function, reduction of RV damage, prevention of PE recurrence, and increased survival. Potential risks include hemorrhage and angioedema, and also prolonged hospitalization if there's any complication from the systemic thrombolysis. Some contraindications to systemic thrombolysis are listed on this slide. Patients or candidates with absolute contraindications, such as prior intracranial hemorrhage, aortic dissection, and active bleeding, should be considered for non-systemic thrombolytic options. For patients who have relative contraindications, such as those listed on the right side of the slide, some experts recommend considering half-dose alteplase or thrombectomy, and the decision ultimately depends on the individual risk versus benefit and the resources available at the hospital. So this is a table describing the characteristics of systemic thrombolytic options. Alteplase and tenecteplase are two thrombolytics that are commonly available. Alteplase is the only one that's currently FDA approved for PE, specifically for massive PE. They both alteplase and tenecteplase work by converting plasminogen to plasmin by binding to fibrin, ultimately increasing fibrinolysis. Alteplase is typically given as an infusion of 100 milligrams over 2 hours, but in cardiac arrest, the recommendation is to give it as a 50 milligram bolus times 2, 15 minutes apart. And tenecteplase is a one-time bolus based on the patient's weight. The half-life of alteplase is very short, but its fibrinolytic activity is known to persist up to 1 hour after the infusion. Tenecteplase is known to have a higher fibrin specificity and PAI resistance. PAI is a glycoprotein that makes up the plasminogen activating enzymes, and a higher PAI resistance usually indicates a longer duration of fibrinolysis. So most studies on systemic fibrinolysis and PE are done using alteplase. The evidence for using alteplase in massive PE is pretty well established, so I won't go over that here. But the role of alteplase in submassive PE is not very clear. So there are some small studies on this topic, and I've included a couple of them here. And these are studies performed on patients with submassive PE with RV dysfunction. And both of the studies were prospective, randomized, placebo-controlled, multi-center trial. Patients either got a combination of alteplase 100 milligrams plus alteplase infusion, or sorry, heparin infusion, or heparin infusion alone. So the first study is the largest prospective study to date evaluating alteplase in submassive PE. The primary outcome for the study was the composite in-hospital death or treatment escalation, and this rate was significantly lower in the alteplase plus heparin group. The in-hospital mortality rate was not significantly different between the two groups. In the second study, the authors found no significant difference in the RV dysfunction at 24 hours and up to 180 days post-randomization in patients receiving alteplase plus heparin drip. PE recurrence, death, or clinical events at 180 days occurred more in the heparin group, but the majority of the events occurred during their inpatient stay, which implied that thrombolysis may improve short-term outcomes. The 180-day mortality rate was higher in the heparin alone group. 6 patients in this group died due to recurrent PE and irreversible RV dysfunction. Unlike the first study, the second study did not allow for rescue thrombolysis or treatment escalation, which may have impacted the difference in mortality. In both studies, the major bleeding rates were not significantly different between the two groups. So overall, there seems to be some benefits of giving alteplase in submassive PE with RV dysfunction in terms of improving treatment escalation rate or short-term outcomes. However, the effect on mortality is mixed and unclear. So another controversy surrounding alteplase use in PE is reduced versus full dose, especially in submassive PE. The Moffitt trial was an open-label randomized controlled trial that included patients with moderate PE. The investigators defined moderate PE as the presence of 2 or more signs and symptoms of PE, plus imaging confirmation and CT or VQ scan. Intervention involved low-dose alteplase, which was defined as 0.5 milligrams per kilo to the max of 50 milligrams, given as a 10 milligram bolus, and then the rest as an infusion, versus anticoagulation alone. The primary outcomes were pulmonary hypertension and the composite endpoints of pulmonary hypertension and recurrent PE at 28 months. The thrombolysis group had a significantly lower rate of the composite outcome of pulmonary hypertension and recurrent PE. There was no difference in death and no bleeding was reported in either group. So the authors concluded that the half-dose thrombolysis is safe and effective in moderate PE. However, the study should be interpreted with caution because the type of patients included in this trial was not the typical submassive PE patients who usually qualify for alteplase. So, for example, only 21% of the patients in the study had RV enlargement and 6% had RV dysfunction. So also the quality of data collection is questionable because there was 0 bleeding event documented in either group, despite the use of anticoagulant and thrombolytic agent. So this was another study looking at half-dose alteplase. It was a retrospective cohort study, including patients admitted to the ICU with PE. They didn't specify which type of PE the patients had, but the patients who, most patients who were receiving pressors were more likely to receive full-dose alteplase. So patients either received half-dose 50 milligrams versus full-dose 100 milligrams. The majority of patients received full dose. So the need for treatment escalation was higher in the half dose compared to full dose group, mostly driven by secondary thrombolysis and catheter thrombus fragmentation. Hospital mortality and bleeding rates were similar. So the authors for this study concluded that half dose alteplase was associated with similar mortality, but higher treatment escalation compared to full dose. So at this time, the benefit of half dose over full dose is not very clear, and the risk versus benefit should be weighed for each patient. I think overall, a more pertinent question that we face in clinical practice is whether to even give alteplase or not, especially when it comes to submassive PE rather than half versus full dose alteplase. As I mentioned earlier, tenecteplase has some benefits compared to alteplase, such as faster infusion time, higher fibrin specificity, and longer duration of fibrinolysis. It's used as growing in other indications such as ischemic stroke. So what are the data for its use in PE? The PERT trial was a randomized double-blind study that included patients with intermediate PE. Patients received either tenecteplase plus heparin drip versus placebo plus heparin drip. The primary outcome was death or hemodynamic decompensation within 7 days, and this was lower in the tenecteplase group. There was no significant difference in the rate of death alone. However, the tenecteplase group had significantly higher rate of major bleeding compared to placebo. So as you can see in this graph, tenecteplase was favored in improving hemodynamic decompensation outcome, but not in preventing major bleeding rates. So this was a follow-up study to the PERT trial that involved about 70% of the patients originally in the trial and was conducted 38 months after the trial was performed. All of the outcomes that were studied, including mortality, persistent dyspnea, or functional limitation, and CTEPH had no difference between the two groups. So the authors concluded that there is overall no difference in the long-term effects of tenecteplase in patients with intermediate PE. The results may have been different if this was studied in massive PE patients, but at this time, tenecteplase is not favored over alteplase due to its high bleed risk. So in cardiac arrest, the ACLS guidelines recommend early administration of systemic thrombolysis because it improves resuscitation outcomes. Ongoing CPR is not an absolute contraindication to fibrinolysis, although there may be uncertainty of diagnosis and benefit during cardiac arrest. The risk of death overall outweighs the risk of bleeding from thrombolysis, so the guidelines do recommend giving it if there is a high suspicion for PE. So the recommended dose of alteplase, as I mentioned earlier in cardiac arrest, is 50 milligram bolus followed by a repeat bolus in 15 minutes if no ROSC. Alternatively, tenecteplase can be used as a single weight-based dose. Thrombolytic can be administered with or followed by systemic anticoagulation. So these are some studies looking at the dose of alteplase in cardiac arrest. They are all small retrospective studies. Unfortunately, the PERT trial, the first one, used alteplase 50 milligrams times 1 and heparin drip. So about 96% of patients achieved ROSC and hemodynamic stability. ROSC was achieved in these patients about 2 to 15 minutes after receiving alteplase, and there was no bleeding events. So the second trial by PERT and colleagues had a few different dosing strategies, and the 50 milligram single bolus was the most commonly used dose. The time from cardiac arrest to alteplase administration was significantly shorter if just the bolus was given versus infusion, which was expected. There was no difference in ROSC and survival to hospital discharge, but there was 2 major bleed cases in the bolus plus infusion group. In the last trial, patients either received no thrombolysis or alteplase 100 milligrams. The rate of ROSC achievement was much higher in the alteplase group than no thrombolysis group. The rate of survivors was higher in the alteplase group as well, although this was not statistically significant. So overall, alteplase given as 1 or 2 doses of 50 milligram bolus rather than infusion during cardiac arrest seems to be effective in achieving an early ROSC and improving outcomes. So when choosing an anticoagulant, there's many options. In the inpatient setting, providers may prefer IV or sub-Q option initially and convert over to a PO option later. Alternatively, if the patient has a non-fulminant low-risk PE, they may get an oral agent from the start. Patient-specific factors can be considered in special cases when choosing a long-term anticoagulant. For example, low molecular weight low molecular weight heparin or oral 10A inhibitor is preferred in cancer-associated VTE, and warfarin is preferred in antiphospholipid syndrome. So for the initial choice of anticoagulation in massive or submassive PE, providers often choose heparin drip due to its shorter half-life in case there's a potential need for an advanced procedure. However, compared to low molecular weight heparin, unfractionated heparin has unpredictable pharmacokinetics due to its small volume of distribution and variable half-life. So as a result, it's challenging to achieve therapeutic levels compared to low molecular weight heparin. Some considerations with low molecular weight heparin are obviously its longer half-life and caution when using in patients with renal dysfunction. So the PERT team at Mass Gen Hospital performed a retrospective analysis from 2012 to 2017 on over 500 patients who received heparin infusion for PE. As you can see in the table below, even at 48 hours, the proportion of patients who achieved therapeutic PTT goal was very low, less than half the patients overall. And there were no patients who had all PTT levels within the therapeutic range during the first 48 hours of heparin therapy. So in high-risk PE patients, we all know it's important to achieve a therapeutic level as soon as possible, but the study shows that heparin drip may not be effective in achieving and maintaining a therapeutic range in a reasonable time. So in clinical practice, some providers may feel more comfortable initiating heparin drip because of the potential need for an advanced therapy. However, in this particular study, only 10% of the PERT patients ended up undergoing an advanced treatment, showing that very few PE patients in clinical practice end up needing heparin drip for the purpose of turning it off later. So this rate may depend obviously on depending on the clinical site, but in practice, we should reconsider whether all patients really need to be on IV heparin drip or if some patients can benefit from getting Lovenox. This is a Cochrane database review of 29 studies, including over 10,000 patients, comparing fixed dose low molecular weight heparin versus adjusted unfractionated heparin in VTE. It's a bit busy slide, but essentially in summary, the review found that fixed dose low molecular weight heparin was superior to adjusted unfractionated heparin in decreasing the incidence of recurrent VTE, reducing the thrombus size, and preventing major hemorrhage. So there was no difference in mortality. The data was mostly moderate quality evidence with the exception of the reduction in thrombus size, which was low quality. The results from this review further validates the potential benefit of using low molecular weight heparin versus unfractionated heparin VTE. So in conclusion, for my part, alteplase is recommended and approved for massive PE. The data in some massive PE is not as clear, but there seems to be potential benefits. There's not enough data to support half versus full dose alteplase at this time. If a decision is made to give alteplase for some massive PE at all, I would lean towards giving the full dose unless the patient has a significant bleed risk and there's no access to other non-systemic treatment options. Tenecteplase is not recommended as the first-line agent due to some studies suggesting a higher bleed risk. And cardiac arrest prompt administration of alteplase is recommended in suspected or confirmed PE and divided bolus doses of 50 milligrams up to 2 times. And lastly, the choice of anticoagulant should depend on the individual risks, and providers should keep in mind that it may be difficult to achieve and maintain therapeutic levels with heparin drip. Thank you. That is it for my section. With that, I'll be handing it back over to Dr. Lee.
Perfect. Well, thank you guys so much. Like, I'll try to buzz through this really quick. I know we're running out of time, but I give a lot of credit to Robert and Naomi for going through kind of the big heavy lifting of the PE that we wanted to hit on. And I think a couple different key features, just to not dumb it down, but I'm a simple-minded person. I think really looking at the IVC from the echocardiogram for the novice person is something really useful or beneficial as kind of an entry-level point. And then to backpack off the anticoagulation, I think there is a huge interest in potentially using low molecular weight heparin. Of course, discussing with your interventionalist beforehand. But again, I'm biased to our institution here. It's something that we really want to make a push for. Changing that over, I think getting someone anticoagulated in a short period of time, because we know the mortality up front is the highest versus days down the road. And I think the data is really behind Lovenox getting that done much quicker. So I really appreciate them doing the heavy lifting. I know Bob spoke a lot, but I know he has a lot of interest in this world. Excellent in regard to echocardiogram, and I would truly believe that he's really read all those books that are right behind him. So we really appreciate that, and both of them presenting that. I'll buzz through here real quick the last couple of slides in regards to more advanced therapies, as we know, a couple of reperfusion techniques, then of course ECMO if you have that available. The huge probably lecture point would be catheter-directed therapies. That is kind of the hot topic as of late. That's where you're seeing these fancy name trials, the FLARE and FLAME and Peerless 2 and all these different studies that are really looking at that high risk intermediate and contraindication TPA groups and saying, is a catheter the way to go? And it seems like the push or the trend seems to be that those are only increasing as the years go by. Obviously, critical care seems to be very cyclical, so who knows in 10, 15 years, but there's going to be hopefully more information soon as those studies are still pending. So I wanted to show you guys real quick here a couple of just the catheters, the lysis one on the right, the more mechanical thrombectomy on the left, which is really what we're using a lot more nowadays. I know the lysis catheter was one of the first ones, and now we're seeing more immediate results with some of the mechanical thrombectomy devices and really seeing some awesome hemodynamic changes. So I put a couple quick pictures on here just to show a couple patients we did. Again, I just kind of purpled them out, if you will, just to get them brand non-specific. We definitely have no bias or no factor with any of the brands whatsoever, no conflicts of interest, if you will, but really seeing their hemodynamics get better, people even come off oxygen while you're doing the actual procedure is quite fantastic. And I think as the studies continue to evolve, I think this will be something that we'll continue to see into the future. And just lastly, as we've all been hitting out this whole time, I think this topic is so interesting. And as the data was presented, it seems like, hey, this area we know, but there's a whole group of this gray zone, and really trying to tease that out through the PERT approach and really have a multidisciplinary discussion is key. I think time is valuable when it comes in regards to this and getting people anticoagulated into their definitive therapy as quickly as possible. And what we didn't talk on too much with PERT has also been a big deal with follow-up. So not only just treating them in the acute setting, but then keeping an eye on them on the outpatient setting, all with the goal of basically standardizing our care for all this gray area as we move forward throughout our all institutions. So I appreciate it. I know we ran over by a few minutes, but we really appreciate your time and the opportunity today.
Thank you all very much for that lecture to us. So at this time, if anybody has any questions they want to ask, please put them in the chat box and I'll make sure to read them so everybody can hear them, especially when this gets posted on YouTube for others, or if you want to go back and listen. Try and entertain maybe one or two questions that we've got here, if we have any. I'm not seeing any at this time. Thank the three of you very much. We really appreciate it. Everything that the time and effort that you put into this, and it was very educational. This will be posted to YouTube, and we'll, oh, hold on, I think we got one more that just said thanks for the talk. Okay. All right. Well, thank you, everyone. And our next bite-sized lecture will hopefully be early 2024.